Good morning. Welcome to my lecture sessions on anesthesiology. Today we'll deal with deep vein thrombosis and pulmonary embolism, which is of vital importance in the post-operative period. Sudden death of the patient can occur with this. DVT, that is deep vein thrombosis, and pulmonary embolism, PE, are the major causes of significant morbidity, mortality, which are frequently but not exclusively associated with surgery, injury, and other reasons for hospitalizations. DVT of the lower extremity is subdivided into either distal, that is cup vein, or proximal, that is popliteal, femoral, or iliac veins. Thrombosis. Proximal vein thrombosis is of greater importance since it is more commonly associated with pulmonary embolism. Prevalence. The estimated annual incidence of venous thromboembolism from a 25-year population based study is about 117 per 1 lakh. And this increases up to 900 per 1 lakh by the age of 85 years. Approximately 30% of these patients, around 6 lakh per year, develop symptomatic PE. Up to 2 lakh deaths annually in the United States are either caused or related to PE. Risk factors, pathophysiology, and embolic occlusion in the pulmonary circulation increases the total dead space. A theoretical increase of a PaCO2 is expected but often not clinically observed due to compensation from increased minute ventilation triggered by medullary chemoreceptors sensing the rise of PaCO2. Risk factors for DVT and PE. Risk factors for DVT: alterations of blood flow, that is stasis, injury to vascular endothelium, abnormal blood coagulation, also known as triad, that is hypercoagulability, hemodynamic changes, and endothelial injury or dysfunction, which is often present in the perioperative period. Risk factors like malignancy, trauma, inflammatory bowel disease, immobilization, surgery, especially orthopedic, presence of a central venous catheter, oral contraceptives, pregnancy, sickle cell anemia, and hormone replacement therapy. Causes of venous thrombosis: inherited disorders like protein S and C deficiency or antithrombin deficiency. In acquired disorders comes the malignancy, trauma, inflammatory bowel disease, immobilization, surgery, especially the orthopedic, presence of a central venous catheter, oral pregnancy, oral contraceptives, pregnancy, and sickle cell anemia and hormone replacement therapy. When hypercapnia becomes evident, massive PE should be suspected. Hypoxemia is more often seen during a PE, BQ mismatch in which there is dead space ventilation in some parts of the lungs and overperfusion in others. Atelectasis caused by loss of surfactant within hours after PE. Right to left intrapulmonary shunting when overperfusion and decreased vascular resistance occur in non-embolic parts of the lungs. Intracardiac shunting may occur due to increased pulmonary artery pressure and enlarged opening of pre-existing foramen ovary. A pulmonary embolus reduces the cross-sectional area of pulmonary vasculature, resulting in increased pulmonary vascular resistance. In addition, intrapulmonary reflexes stimulate the release of humoral substances that lead to vasoconstriction throughout the lungs and thus further increase pulmonary vascular resistance. As a result, high pulmonary arterial pressure could acutely develop, especially in patients with pre-existing cardiopulmonary diseases, and potentially precipitate or lead to acute right ventricular failure. A pulmonary embolus. Here we come to the conclusion of this video. Next part of this lecture will be continued on the next video. Thank you.